Prostate Cancer Research Institute is an educational organization for prostate cancer patients, their caregivers, and their families. We put patients first and are an unbiased source of information and support. For over 20 years, our goal has been to meet the educational needs of prostate cancer patients at every stage of their journey. Medical technology is advancing rapidly, and new treatments are becoming available. Patients have to make complex choices which have lasting implications. They face unexpected industry biases and doctors who may not be up to date on the latest research. Your donation helps men receive the latest, most up-to-date information, which empowers them to make informed decisions. Our website, PCRI.org, is a wealth of information and resources. Our conferences and webinars are a way to get patients' questions answered by leading physicians and researchers. And we have a helpline for men to call with questions about their diagnosis, treatment choices, and side effects associated with these treatments. Each week we produce multiple videos covering concepts and every patient question that we can think of about the disease in a straightforward and easy to understand format. This was a brief overview of what we do at PCRI, and to learn more you can visit our website. Your donation directly funds our educational programs, which give life-changing information to men during a very vulnerable time in their life, and we thank you for your consideration. You can visit PCRI.org to learn more. Hi everyone, I'm Alex with the PCRI, and welcome to our latest webinar. Today we're going to be hearing from our favorite moderator, Dr. Mark Moyad from the University of Michigan, and Dr. Laurence Klotz. We call him the father of active surveillance. He's an incredible person who works in Canada with Sunnybrook Health, and he's actually been knighted in Canada. So he's an incredible person who's done so many papers on active surveillance, and their center started recently doing Tulsa Pro. So the webinar you're going to be hearing is Dr. Moyad asking him questions about Tulsa Pro, the ins and outs, how it works, and all the information that we really want you to know. If you have questions about anything, you can visit our website at pcri.org and email us at info@pcri.org as well. I hope you enjoy the webinar.
Welcome, ladies and gentlemen, to this special extra credit edition, and I mean extra credit edition of PCRI / Dr. Moyad / Dr. Klotz Overtime. And we call this the Overtime Naked and Afraid moment, which means, again, if you missed the 2-hour interview I had with Dr. Klotz for the annual PCRI meeting in September. It's available on video. I know thousands have seen it, but I was frustrated because I wanted to get to one more question on a clinical trial he helped initiate and just published on. So I asked him to come back and return sometime, but only if he gave me about 30, 45 minutes so we could also include his incredible piano skills at the same time. So we decided to actually carry out what we meant. We decided to actually do this. So it's a weekend here, and he's in Toronto. I'm in Ann Arbor, Michigan. And so I'm glad you could join us for this special extra credit event. Dr. Klotz really needs no introduction. They call him the father of active surveillance, used to be called watchful waiting though, and published 6 bazillion articles, done every possible thing in this world. Probably he's best known for being friends with me. And I think that's why most people stop him on the street. But really, he is the father of active surveillance. I don't even know if we would have active surveillance globally as popular as it is and as effective as it is without his intervention. And he's still so active, it's become ridiculous. I mean, he has 5 talks today for a meeting, a very important special international meeting, and making time for us. So Dr. Klotz, I want to first welcome you, and I want to ask you if I missed anything else in your CV besides you're one of the most famous urologist individuals, doctors in the world. I mean, I'm not trying to pander, but there's a reality to that.
Yeah, you've always been prone to understatement, Mark. No, that's over the top, but thank you for that.
Yeah, you know how I feel about you. We've been friends, as a conflict of interest. We've been friends for a while, but at the same time, we're not scared to talk objectivity, be a little critical of each other and what we're doing. And part of this series that we initiated was, I'm used to 25 years, 30 years with these amazing individuals where we just talk offline like this. We don't do slides. And I thought, wouldn't it be nice to finally do that in a series of interviews? Let's quit with the slides and let's just talk off the cuff. But a couple of years ago, I realized I went to a dinner at UCLA, and Dr. Klotz was there. And after dinner was over, he said, I'm going to get up and play the piano. And I actually thought he was joking. And he got up and he played it, and I recorded it without his permission. And I started showing my wife and other people. I said, I thought this guy, all he does is medicine. How does he have a hobby? And I said in the last interview, if I come back and we talk about Tulsa or we talk about active surveillance, you've got to show off some of your piano skills. So you're at home right now, right? In your apartment? Okay. Can you walk us through what you're about to play, or maybe give us a little introduction into how you got involved with the piano and why the piano over, say, the cello or the clarinet?
Well, I think, musical talent is very common in the medical profession. And I came from a musical family, although I had a lot of doctors in my family. But, my father was a drummer. I have 3 brothers. They all played an instrument. We had a family band. And so, I, like every other kid, hated the piano, hated practicing. But my mother was a forceful woman. Every time I said, I'm going to quit, I can't take it anymore, she said, fine, you can quit that teacher. And she found me another teacher. And eventually, when I was in my mid-teens, when everyone quits, I hooked up with this kind of jazz piano teacher, and he got me through that period when it's so common for people to quit. And I've been playing ever since. It's a wonderful hobby, mainly self-taught since then. But I've kind of been a student of jazz ever since. And I also, you may not be aware, I found colleagues who played. So about 10 years ago, we formed a group, a urology rock and roll band called The Void. And that has become a huge success. So we've been playing at meetings all over the United States and Canada. Every time there's a big urology conference, our band plays. And a couple of guys are really phenomenal musicians. So it's been very gratifying to do that.
What's the name of this band? You said it's called The Void?
Called The Void. It's a urology band called The Void. So, and then you asked what I thought I'd do today. So there's a bit of a serious component to this. So we've obviously, we're living through a time of worldwide contraction and really extraordinary, this extraordinary pandemic that's really affected all of us in a negative way. And it seemed for a while like that's all that mattered in the world. And certainly in my environment, the hospital, this is a few months ago, the hospital basically shut down for everything except COVID. And the patients with other diseases, I thought, kind of got left by the wayside because they didn't go away. And so, including obviously prostate cancer, but now, we may be into a second wave, but at least there's sort of an acknowledgement that other things matter, and we don't need to apologize about talking about other diseases. So I wrote this tune. I've been doing this all my life, kind of rewording popular tunes. So I wrote this tune about COVID, which I thought I'd start with.
Sounds great.
All right. Are we ready for that?
The floor, the apartment, your house is yours. I just want you to understand how much I'm morally supporting you today. I have my only piece of Canadian hockey apparel that I own. It was given to me. How do you like that? It's from Nike. It says Canada. It's my hockey jersey. We'll talk about your hockey prowess after you're done with piano.
All right. So here we go. And I would just, not easy to get the audio balance and everything correct here with just a Wi-Fi mic, but we'll try it. All right, here we go. Oh, COVID, you're now here. Although the science is not clear. Transmission going from man to man. From Batsu going someone ate in Wuhan. Till the virus was implanted in my nose by Lord who knows. It is the sound of COVID. In waking hours I walked alone down empty cobblestone. Always wearing my mask and glove. I social distance from everyone I love. And my eyes were stabbed by the flash of a sudden sneeze. Brought me to my knees. It was the sound of COVID. And in the naked light I saw 10,000 people, maybe more. People social distancing, people self-isolating, people avoiding contact as if it's leprosy. Stay away from me. And it's the sound of COVID. And the people bowed and prayed to experts who made them afraid. And the TV flashed out its warning by the message that it was forming. Stay home, wash your hands, don't budge, the message said, or you'll be dead. It was the sound of COVID. And the ORs were all shut. It just hit me in the guts. No surgery was happening there, all because of the viral scare. And the sign said the needs of your patients are written on the OR walls. Clinic halls, they are the sounds of COVID. Fools said, you do not know. COVID's a virus, it will grow. You can't stop it no matter how hard you try. We'll all get infected by and by. But my words, like silent viral particles, fell and echoed in the well of COVID. For a while it seemed like we were saved, until we hit the second wave. We thought we flattened the COVID hump, until it even got to Donald Trump. It's very clear that no one is immune. We're all playing the same tune. It is the song of COVID. And when the pandemic is all done, we will all sit as one. We'll celebrate the things that we once had. Normal life will make us very glad. And we'll say to each other, one day we will arise. We will arise, despite the sounds of COVID. Despite the sounds of COVID. Despite the sounds of COVID. Thank you.
Speech. Speech. If I had a lighter, if I had a match, my wife might get mad if I light a fire in the house. I would light a fire in a concert. Wow. That was impressive. You know what? I didn't know you were going to sing. I just didn't put one and one together. I thought you were going to play piano and say a couple of words. I didn't realize there was a whole thing behind it.
I'm not much of a singer, but I'm a lyricist, so what can you do?
I think the lyrics are profound. I think they make you think, and that was the idea, right?
For sure.
How long did that take you to write? That was a lot of lyrics.
Not long. You know, it's a kind of, if you kind of are in the habit, it comes pretty quickly.
Wow. And you threw the Trump part in there, but he was just diagnosed recently, and so obviously you've been adjusting the song as you've been writing it.
Correct.
Because he was just diagnosed.
He was indeed.
Wow. Remember last time we talked about raising money for charity, Trudeau versus Trump in a cage match? I don't know if you remember.
I remember, sure.
And you thought Trudeau would win, and I that surprised me. But you told me he has a history of boxing.
He took on a senator when he was I think the leader of the opposition, and the senator was an Aboriginal, kind of been a tough guy, and Trudeau killed him. So he's a pugilist.
Wow.
But so is Trump. So who knows?
It'd be interesting. Hey, whoever we have in politics in America is always interesting.
We're not going there right now.
You know that.
Yeah.
It's always interesting. That's all I'll say about that. So you going to do a part 2 to that COVID song, or what are you going to do? Or is that it? Are you a one and doneer?
Well, I can do one at the end.
Okay. I'd like to hear one at the end. I have a bowl in your honor. Since I can't be with you because of COVID, here's the bowl, and I've got a couple $1 bills.
Right.
And so,
that's nice. Yeah.
Had I known that you were going to sing that much, I probably would have put more than $1 bills. I would have put $5 bills in there. I mean, I appreciate that. That must have taken a long time. And when people play that back on the internet, I think they're going to find some very profound lyrics there that I was kind of jotting down as you were singing.
All right. I hope it came through.
It did. It was beautiful. Thank you.
Thank you.
Since we're talking about piano, let's just cover this really quickly. I like to remind people, again, I just don't understand where you have the time, and I'm not even going to be one of those people that, get all gushy and say, oh, he's just so famous, and I don't see how he has all the time for all this. It's amazing. He juggles everything. But the truth is, you also play hockey, right?
Well, listen, I mean, at a serious level, I always thought balance was important in life, and part of it is, physical activity. So, yeah, I play a few sports, but hockey, I still play. It's actually been canceled because of COVID.
Yeah.
But old-timer hockey is very common in Canada, I think. And so I have a group of guys I've been playing with for about 15 years. And I'm probably the oldest now, but, they kind of leave me alone. I get the puck. They let me handle it for a while before they take it away from me. Very, very satisfying sport to play.
Yeah, I think that people would be very deferential to you on the ice because they're going to need you. See,
not bloody deferential enough as far as I'm concerned.
I know, but you need to remind them who you are because as your group is getting older, they're going to need you. They say the dog's man's best friend, but truly the urologist is man's best friend, right? You need to exploit that. You need to take advantage of that on the ice. What else do you do for fun besides hockey?
Well, I play tennis, winter sports, skiing. I've got, lots of intellectual interests, politics, biography, economics, stuff like that.
I've known you a long time, and when you say you look for balance, you're kind of I don't mind telling people what I tell about them behind their back. It never struck me as you were the guy that had balance. You always you produce so much. You produce so many papers, so much research. You have such, you're so busy clinically. I just always thought you were the guy that never gets sleep and is just beating himself up to holy hell. But I think I have that wrong.
I know workaholics. I wouldn't describe myself that way, but partly I've been very fortunate. I'm in an environment where I have the opportunity to do a lot of that kind of research work as well as have a practice and supportive colleagues and so on. So I don't know what the secret is, Mark. Helps to have a lot of energy, but it just all somehow came very naturally to me.
I mean, I think the other secret too we've not talked about is how long have you been there now in that position in Toronto? How many years?
A long time, more than 30.
See that don't you see it? You travel a lot. I see it too. I mean, that's very unusual in today's world. People jump around a lot.
It's I would say it's the norm in Canada. It's a different environment, obviously totally different healthcare system, and it's much more the norm here than it is, I would say, south of the border. Plus, if you're lucky, you find yourself in a situation that's convivial and supportive and where you can do the things that, you can pursue your own priorities. So I've been very fortunate that way.
Yeah, it's been awesome because most of the people I deal with, a lot of people I deal with in interviews, if you've known them 20, 30 years, they've jumped around into 4 or 5 different positions.
Right.
and I understand they think the grass is always greener, but I don't know. I'm lucky here. I'm looking out here at beautiful trees on campus, and I don't know. I don't know where the grass is greener, except maybe, I know you probably think it is in Toronto, but anyhow, let's talk. Let's do a quick review on active surveillance since we talked last.
Yeah.
And we'll talk about this Tulsa procedure a little bit.
Right.
Let's talk randomly about active surveillance just in 2020. Do you see any changes? I mean, is there any comment you want to make? And I know several years ago you had 15-year follow-up data published in the Journal of Clinical Oncology. I looked back on that paper. Is there any just general commentary you want to make on how active surveillance itself has been evolving over the past few years, besides the fact that it's become enormously popular in many places of the world, including the United States?
Well, yeah. So it's really very active at the moment in terms of new developments. So the big changes are in the area of imaging and biomarkers. So, the Achilles heel was always that we knew there was a significant proportion of patients who we were undergrading. We knew they had Gleason 6, but they actually had a higher grade cancer we didn't know about. And that almost certainly is responsible for the few deaths in the surveillance cohorts. We had about 3% at 15 years. Other groups have had in the same category. So, it would be nice if that was lower. And also, of course, we make decisions about who should be treated based on imperfect information. So now we have MRI, which has been a huge advance, although there's some recent data just in the last year or so that it's not as good as we thought it would be. For example, you can't count on the MRI identifying those patients who are progressing. Even when the MRI is stable, about 30% of those patients turn out to have grade progression on repeat biopsy. That's a Sloan Kettering study that just came out recently. The other thing about MRI, of course, is there are many parts of the world where it's not widely available or where it's unaffordable for working class people and so on. And so one of the new developments I'm quite excited about is this high resolution micro ultrasound, which seems to perform about as well as MRI in terms of detecting high grade cancer, but a lot cheaper. The technology is simpler. It doesn't require this multi-million-dollar MRI coil and so on. And then in the biomarker area, this is really on fire. So there are the whole concept is to have an accurate biomarker. You don't have to continue to biopsy patients. You just follow them if it's, say, a urine-based one. And after, say, 5 years, now you have a signal that it's changed. There's there's new molecular genetic signal that the tumor biology is now more aggressive. So that is actually been developed. It's being validated, these kind of assays. Some of them are not yet approved, but they're coming. One that I'm quite excited about is called the Sentinel assay. It was actually just published for the first time in the Journal of Urology a couple of weeks ago. A urine-based, the term is exosome microRNA assay. So it looks at the level of some regulatory genetic material in these tiny exosomes, which are excreted by cancer cells into the urine. And it looks like it really works, like it's going to be accurate enough to really rely on. And if that's the case, it'll be a whole new approach where we don't have to biopsy. We may not even have to image that often. We do a urine test a couple of times a year. And it would make the whole thing obviously more appealing and potentially even safer.
What makes you more confident that these assays will work when we've been hit with a lot of assays in the past several years or past decade?
Because they're getting better.
They're getting better. They're learning from their mistakes.
Well, I think this is how the whole field works. It's like building on previous discoveries. So, yeah, I also think that some of the existing assays, it's partly things like cost, availability, awareness. There's existing assays that really could play a bigger role than they do.
So do you think the average person watching this is thinking about active surveillance or on active surveillance should at least ask their doctor about some type of assay, at least in addition to how they're being followed?
So it depends. I would say we're not quite there yet.
Yeah.
We're not quite there yet, but we're getting there. It's just going to be a matter of a few years.
So people need to be checking back on a regular basis because this stuff moves and moves quickly.
I would say so. I mean, imaging for sure. Everyone in surveillance should have an MRI.
Yes.
or some kind of imaging. And you know, the whole it's a long story about the biomarkers. Like for example, you have the tissue-based biomarkers, the Oncotype DX and Myriad assays and the ProMark assay. But first of all, they cost around $4,000 US.
Yeah.
So it's a significant chunk of change. And in the average patient who's not at that high risk, the concern is the risk of a false positive because none of these assays are perfect. The metastasis rate is so low on a low-risk patient with a few foci of grade group 1 or Gleason 6 prostate cancer that the risk is that by doing an assay that's got, let's say, 90% accurate, that 10% false positive rate may be misleading much more often than the patient's really at risk. So the role of those assays is really in the kind of higher risk patient, which is not the typical surveillance patient.
And you still feel from the last time we talked that age is just a number when it comes to active surveillance. You have people who are very young and who are very old. Is that right?
Well, the controversy is in the very young, say under 50 or under 55. So first of all, there's now a number of publications. We did one of them that in young patients, it's basically the same indolent benign condition. The fact that they're diagnosed younger doesn't mean it's more aggressive at all. If anything, less aggressive because higher grade cancer is more common as patients get older. And we also know from the autopsy studies, there's a key point in the field that microfocal prostate cancer starts early, even in men in their 30s. So this one pivotal study, autopsy study in men who mainly were killed by violence, young men, 30% of the ones in their 30s had some prostate cancer. So you find it because, you do a systematic biopsy, and that doesn't mean they necessarily have life-threatening disease just because they're so young. In the older patient, it's the opposite. We don't want to be aggressive in those patients. And is there really still a role in the elderly for the close follow-up that is the norm for younger patients? So the term is there's a switch to watchful waiting in men as they reach around age 80 in the average patient, where they have around 5 to 10 year average life expectancy. And even if they have higher grade cancer, they're not going to benefit much from radical treatment.
Yeah, but you said something interesting. Higher grade is more common with age.
Yes, for sure.
If you quiz most of the people on the street, including a lot of healthcare professionals, they would think if you're diagnosed earlier at an early age with a cancer, the chances are it's going to be more aggressive. And you're saying that's not the case in prostate cancer.
Well, grade for grade, it's not more aggressive. But what happens, in my view, over time, the low-grade cancer can de-differentiate. So the best estimate is around 1% per year, or 1.5% per year. So you have someone who's diagnosed when they're 50. It just makes sense that over 30 years, they may develop higher grade cancer. And all kinds of studies have showed that in older patients, the rate of higher grade cancer is higher. But it doesn't mean they're going to die from it.
Right.
So, this is the older you get, the less you're at risk. So there's a kind of yin-yang phenomenon.
Yeah. So another one or two quick questions, then we move on to Tulsa.
Yeah.
Last time we talked, and I knew the answer, which set me off on a 20-year mission too, part of those papers that you wrote, was if the number one cause of death in your active surveillance series, which is one of the largest in the world, is cardiovascular disease, why not demand or someone sign a document that says, I'm going to take care of my cardiovascular health while you're watching me for active surveillance. I am going to maybe follow up with my primary care. If I have a cardiologist, I will follow up. But if this is the biggest threat to me when you're following me on active surveillance, don't we want to talk about the elephant in the room up front?
Well, you're preaching to the choir, Mark. I mean, I agree with you 100%. I don't know about signing a document. It's a bit like
That was dramatic.
A marriage contract, or I don't know, joining the Masons or something. But yeah, I mean, if what you're saying is, I mean, this is what I preach, that often you see a guy on surveillance, he may not be seeing any other physicians. He's seeing you because he was diagnosed with low-risk prostate cancer. And so you have a responsibility to act in some ways as the patient's primary care physician. And by counseling, diet, exercise, et cetera, you're probably doing more for his health than by managing his prostate cancer.
Right.
Smoking cessation, of course, the other big one.
Absolutely. There's a quiz, and you can try it. You can try 100 consecutive patients. You can even talk to practitioners who have prostate cancer. And you say, what was your PSA on November 8th, 3 years ago exactly? And they'll go, 2.4. They'll tell you exactly. Then you go, okay, by the same time period, what was your LDL, your bad cholesterol? And they go, wait a second, is that the good one or is that the bad one? Anyway, it was good. My doctor said it was good. And you know, even the doctors I talk to talk that way, a lot of them. And it's our job to switch the narrative, right? I know I'm preaching to the choir. One more thing. Last time we talked, I said to you, what are the chances in 3 or 4 years that everybody's getting some kind of DNA mutational testing, genetic testing? And you said probably it's going to pick up. So I see all these guys going into active surveillance, and I'm looking at your new paper on Tulsa that just came out, which again, that's our next topic.
Yeah.
And near your paper was a paper from Israel looking at short-term outcomes of active surveillance for low-risk prostate cancer among men with germline DNA repair gene mutations.
Right, I saw that.
Did you see that?
I saw that.
This is making me think that we're not going to wait 3 years, Dr. Klotz, that in a year or two, everyone who goes through active surveillance is going to get BRCA testing and other germline testing. Am I crazy or am I right?
Well, you know, I'm much more supportive of the idea of basically applying resources selectively, right? Like I'm not, overall, maybe 3% of the population has one of these germline mutations, and in the prostate cancer patient population as a whole, maybe 5 to 10%. So if you have someone, you know, no family history, a few microfoci, I don't know. I'm not sure he needs it, but any flag, yes. And basically, if you're saying since it's become relatively inexpensive, just a couple of $100, why not do it in everyone? I can't argue.
Thank you. Well, the paper also said overall 20% had upgrading at confirmatory biopsy and were treated. And in the paper, you kind of looks as only 20%. I'm going, wait, last time I checked, 20% was 1 out of 5. That's not a small number. So I'm just saying that here it comes. Here comes the wave. It's another, you have to always be scared of those Moyad predictions. They come true all the time. I'm interviewing you a year from now and you're doing this, I bet.
All right.
Okay, let's talk about transurethral ultrasound ablation of the prostate called Tulsa. I did not know, I knew little to nothing about it. And my urology colleague said, you got to ask Klotz about it, ask Klotz about it. He's kind of running the show here. He's involved in the research. And I did some research and I thought it was interesting. I thought there were a lot of catches. So first tell me the introduction to Tulsa, how the concept began, just the early history of why you're even doing this. And then we'll go into where it is now.
Yeah, so this actually came out of my institution, Sunnybrook. And I met a guy, this goes back probably 13, 14 years, who was a young postdoc fellow in our institution. He's a physicist, biophysicist, Rajiv Chopra. And this is his idea, although the group, it's a very high quality physics imaging research group in our place. They had this long-standing interest in the use of ultrasound energy converted to heat to non-invasively treat various diseases. And the whole area of focal therapy with focused ultrasound is huge in many specialties, including neurosurgery, for example. So that's been another big initiative to treat Parkinson's with this kind of non-invasive focal ultrasound therapy. So he and I basically worked on this for a long time. We did in silico, which means kind of computer modeling, gels. We moved on to canine models. That was several years. And then we did the first in human, which was a so-called treat and resect study where we did the treatment, and then I took the patient in the operating room and took out their prostate to see what it actually done. And the basic concept is to use focused ultrasound or ultrasound energy, which acts a lot like light with a magnifying glass. So, you know, you can obviously at the focal point of a parabolic beam, you get very concentrated energy. And so that's kind of how ultrasound is used to generate heat and to cook or thermally ablate tissue. But the other big advance here was the use of real-time thermal monitoring or thermography. So MRI has the capability of producing a real-time thermal map of the tissue that you're imaging. And in a normal situation, that would be of absolutely no use because every tissue in your body is basically 37 degrees centigrade. What would be the point of having a thermal map? But if you're using a thermal-based energy to treat something, then the idea of a thermal map that tells you what temperature is being achieved by the treatment is phenomenally useful. And the technology, which took about 10 years to develop, is called closed loop thermography guided transurethral ablation. And the idea of closed loop means what happens is the MRI, a transducer is put into the prostatic urethra, kind of like a cystoscope. And it's got these 10 5-millimeter transducers on it that sit in the prostate. So it's 5 centimeters long, which is the length of most prostates or less. And what happens is the MRI gives you a slice at 5 millimeters. So you have these 10 MRI slices, and then you turn it on and the energy is produced by each one of these transducers, and it heats up that little slice of tissue. And you see a real-time map. Here, pictures are worth 1,000 words, so we don't have slides for this talk, but you'll have to imagine it. You see on the screen, the tissue changes color, and you mark out your target initially, and when the entire tissue that you're treating reaches the target temperature, say 59 degrees, the energy that's delivered to that transducer stops. And when the whole area has been treated, all 10 slices, the transducer starts to rotate. And so you can treat the whole prostate this way, and it's quite quick. It takes about 40 minutes to ablate an entire prostate. So it's kind of the next generation of focal therapy with HIFU, for example, or cryosurgery. And the appeal of it is that it's very precise, and it's also basically quite automated. So the state of the art now is that this was developed. There was a biotech company that was spun off to commercialize it. The trial that was just published was the pivotal registration trial in about 120 patients in 5 different countries, about 15 different sites. And it worked, and it got FDA approval maybe 6 months ago, and now it's at the point where it's being rolled out as a therapeutic option. There's a couple of places in the United States that are doing it. There's a place in Germany, the Alta Clinic, that's been doing it for a while, and we are hoping to roll it out sometime in the next few months at my institution in Sunnybrook.
So the first thing I want to talk to you about before I get into this trial and what just published, and they can go to the Journal of Urology and take a look. And for those of you who are looking to see what this looks like, it took me 3 seconds on Google to type in Tulsa and Tulsa video, and the video came up from different sites. Now, the first thing that might come up is Tulsa, Oklahoma. That's fine. That's a nice place, but you move on. But transurethral ultrasound ablation of the prostate videos, you'll see that come up right on Google very quickly. It can show you what he's talking about in terms of pictures. What a lot of people don't realize before I get into the prostate data is that this is also targeting, or at least some of the researchers, maybe you're one of them, are excited about the potential for it to treat prostate enlargement that doesn't have cancer or BPH. Is that right?
So for sure, this could be used to treat benign prostatic enlargement. The difference is that you have a lot of competing technologies now to treat BPH, and a lot of them are also minimally invasive and work quite well. So I don't think you would set up a Tulsa program just to do BPH. But if you've got a Tulsa program to treat prostate cancer and have the expertise and the team, then it really, I think, it would be a very nice option to use it for BPH. Now, to the best of my knowledge, there's not a single patient that's been reported on yet treated for BPH. But we know from the prostate cancer study, it reduces the prostatic volume by about 90%. So it's really amazing. Like the initial average prostatic volume was about 40 cc's in this group of patients, and the post-treatment volume, the average was 4.
That really shocked me. So if I got a tennis ball, if my prostate's the size of a tennis ball, that thing gets down to a walnut. You know,
More like
really,
a pecan.
More like a what?
More like a pecan.
Yeah, no, more like a pecan. You're right. I mean, so that was one thing we're going to cover. So this trial was called, well, a lot of these men have BPH and prostate cancer, so that'll be interesting to watch how this plays out.
Yeah.
This trial was called the Tulsa Pro Ablation Trial, and so TACT, T-A-C-T. Right. And again, there was over 100 patients, 13 medical centers. And let me take you through, because I talked to Scholes and a couple of my friends, my urology friends, and they wanted me to ask you, some questions, because everything comes with a catch, or pros versus cons. So let me walk you through these for the rest of our time, and you take us through it.
Right.
If I was critical of the study in several places, I would say, you still only treated favorable Gleason 7 disease, and you seem to have a lot of Gleason 6. I understand you like to use the word grade group, but that confuses patients watching because they still know Gleason 6, 7. But my point is, about 38% had very favorable disease, and a number of these guys were older. So my first question is, why even treat a number of those guys in this trial? They look like perfect active surveillance patients.
So listen, that's a totally legit criticism. I was not in favor of including the Gleason 6. But all I can tell you is, it's a challenge to launch new technologies. There's a lot of hurdles. And if you're offering something that's basically brand new, like when we launched this trial, there'd been a grand total of about 45 patients treated this way. So and you're trying to get patients to voluntarily agree to subject themselves to this. It's not easy. So if you make your eligibility criteria too narrow, it becomes impossible. So the idea was to offer this to patients who had, in most cases, more extensive Gleason 6, who just weren't happy being on surveillance. I can tell you, personally, I didn't have any patients who were Gleason 6 who I put on this trial, because I didn't think they needed treatment. But, this is not a universally accepted perspective. Some people think that's a little too radical, and that you should offer it to young patients, for example, who have extensive Gleason 6. So, it's not a black and white thing. It would have been a better study if we'd only done patients with what is widely considered to be clinically significant cancer, grade group 2 or 3, Gleason 6. But sometimes, you have to acknowledge practical considerations.
No, I understand that. And, it is a valid criticism, because you're sort of the king, or you're the emperor, I don't know what the word is, of active surveillance. And here there's a bunch of guys who could be just still following active surveillance getting treated by this therapy. However, in your defense, this idea that life is so black and white, that everybody on Gleason 6 is going to be kumbaya and say, no problem, follow me, I never want to be treated, is ludicrous. Right. It's ludicrous.
Right, right.
In the TAC trial, okay, so then they had to undergo biopsy a year after treatment. Well, but how does that work in the future? This is now FDA approved. So does everybody have to have a biopsy a year after treatment?
So I'd say a couple of things about that. This was in a clinical trial setting. So the fact that you need, the term is a readout. You need a readout that is very robust and meaningful to really be convincing. So there's nothing more meaningful in this area than a post-treatment biopsy. And the focal literature has been criticized, the focal therapy literature has been criticized justifiably because a lot of the publications don't include a post-treatment biopsy. So I really felt, this was adamant. Now, if someone has this treatment or has focal therapy in general, I still think the state of the science is such that I really encourage patients to have at least one biopsy after the treatment to make sure it was effective. And, if that's the worst part about the treatment compared to the long-term side effects of radical therapy, it's really a small price to pay. And then finally, in kind of practical considerations, if you have a patient where the PSA is dropped by 97% and their imaging shows no evidence of residual cancer, and particularly no enhancement on the multiparametric MRI, which is one of the parameters, patient said, I don't want another biopsy, I wouldn't push too hard. But it's really, there are guys where the PSA doesn't change that much, where the MRI shows a suspicion of some residual cancer, where I really think it's mandatory.
Okay. Well, going to PSA change, in this trial, it seemed like the PSA nadir in the cohort rose from a certain point level, like a 0.3, and then started to move up after a few years. So when that PSA is moving up slightly to 0.3, 0.5 in a number of these patients, what's the thought process there? Is the cancer coming back? Do you think this is just the prostate growing after applying so much energy, it's starting to regrow, or what's the deal here?
So, no treatment is perfect. I don't get too excited about rises in PSA at a very low level. The patients still have the prostate. This is true of focal therapy in general. The patients still have their prostate. So, that is the strength and the weakness of these minimally invasive therapies. They have preservation of quality of life, but they may still have some epithelial cells that make PSA. And in the TACT trial, it was about 20% of patients still had some residual significant cancer. So, it's always going to be the case that patients treated this way need to be followed. They need to be re-imaged, in some cases rebiopsied, and probably consistently around 20%. Doesn't seem to matter which technology it is. There's around a 20% failure rate. One of the appealing things about this whole area, whether it's HIFU or Tulsa or cryo, is you have good salvage options. You can give radiation, you can operate, you can retreat without the same risks that you do with salvage treatment after radiation. Radiation impairs the healing process. So operating on a patient after radiation is very fraught. A patient that doesn't heal is basically a surgical disaster. So it gives you some options for the roughly 20% who fail. And the other thing I should just emphasize, this is really still the learning curve. Like every center that was doing this, these were either their first 10 or 15 cases, or in our case, we'd already done about 25. So, but we're still under 50 cases, even though we're one of the most experienced centers in the world. So it's going to get better with time.
I was looking, I saw in the Scandinavian Journal of Urology, I think that was it, and I think a number of them were Canadian urologists. They did surgery after some Tulsa patients had failed. And the implication from the paper is, I don't want to microdissect it, but their implication was they put a very favorable commentary on it that they still could do surgery in these patients and the morbidity or the side effects were still acceptable. Now I know. So is that true or not? So,
these are questions that need to be answered. Like, I personally have never operated on a patient post-Tulsa. There is some data after HIFU that the surgical margin rate is higher. And that doesn't surprise me at all because you get scarring and fibrosis, particularly with transrectal HIFU between the rectum and the prostate, and the neurovascular bundles are in that region. And so it's not surprising. I usually encourage patients, unless they're quite young, who have failed one of these thermal ablation therapies, to go for radiation, because there I think there's no evidence that the complication rate is any higher. And so you don't have that whole issue of the effect of the treatment on ablating surgical planes that normally the surgeon relies on to make the operation safe.
Yeah, because you're still throwing a large dose of energy at this tissue, and things happen when you throw energy at the tissue. It makes the surgery harder, right? So, I mean, afterward, yeah. And so that's an interesting, you're saying if someone had to do salvage surgery, so they had Tulsa or one of these other treatments, but let's say Tulsa, and they came back and they had to pick between surgery and radiation, you would actually lean more toward picking radiation.
It's not black and white, but yes.
That's interesting. Yeah. I think that's really interesting, actually. All right, let's talk about the procedure here, because even though we're using the words transurethral ultrasound, we're not explaining it. You're sticking this thing in my penis, not my penis, but I mean, this is kind of scary. Like, you're sticking the device in my penis, right? You're going up into the prostate. I know you don't like me using those words, but nobody necessarily loves that. And then they're being put in an MRI machine. Will you walk me through this process and why I shouldn't be so intimidated by it?
No. So first of all, that's what urologists do. Second, the thought of it is considerably worse than the reality by and large. But I think probably most important, this is done under general anesthesia. So the patient doesn't experience any discomfort during the entire procedure. And afterwards, they may have a little bit of burning, but minimal. So keep in mind, we're talking about patients under general anesthetic. So basically the way it works is the first step is to put a telescope up into the bladder and put in a guide wire through the telescope that guides in what's called the urethral applicator. So then the patient is anesthetized. He's moved into the MRI core on a special stretcher that goes into the MRI core. The core is the term for the big donut. And then you, as the urologist, you put this applicator in over the guide wire. You put a cooling device, a little cooling balloon in the patient's rectum. And then the patient goes into the middle of the core and everyone steps out of the room and you image and check to make sure that everything's in the right place. That's one of the things that can be time consuming. And so when you you do the adjustments, when you have the transducer in exactly the right place, so it's now you got these 10 transducers lined up from the base of the prostate to the apex, and you image and you see the image on the screen of the MRI, and then you outline the target that you want to treat. So you can outline a fraction of the prostate and do partial gland ablation or focal therapy. You can outline the whole prostate. And once you have that done, you do a couple other minor things to reduce movement, bowel peristalsis, for example. One of the pitfalls is that the thermal mapping feature interprets movement as a change in temperature. So it's absolutely vital that the patient and his internal organs be immobilized. You wouldn't think that's a big issue, but for example, the kidney moves with breathing, and it moves enough that you will not be able to use this technique for the kidney. The brain, in contrast, is immobilized inside the skull, so it lends itself to this. So that's a limitation in terms of applying this to other disease entities. But movement is a problem. And that's also one of the pitfalls of the treatment. So for example, the patients had their GI tract, they've had a bowel preparation. And so the poop is cleared out of the GI tract, but you can get air bubbles.
Yeah.
So one of the frustrating things with this is you got a whole team of people and you're ready to go. And there's a little 5 millimeter air bubble floating around in the patient's rectum. And the machine, the MRI, detects this as a change in temperature. It has an automatic shutoff if it looks like the rectum is heating up. This is one of the safety features. So everything stops. And you've got a whole team of people looking at this 5 millimeter air bubble on the MRI and how are we going to get rid of that thing? So these are just some aspects of the learning curve that we went through and that everyone who is doing this went through. These are all manageable problems, but that's why even though the treatment itself is quite quick, less than an hour, the total treatment time from the time the patient's anesthetized, the time they come out, typically takes about 3 hours or even more.
So you just stole my thunder. And what I mean by that is that kind of makes me a little, that's one thing. If I had to tell you personal nervousness, there were a couple sites and a couple places said, hey, average treatment time is 50 minutes, 48 minutes, 52 minutes. But the truth is the total procedure time really can run 3-4 hours. And I
Absolutely.
think that should be next. That should be the asterisk that's right next to the comment that, hey, this only takes about 50 minutes to treat you on average. But by the way, your total commitment times can run, in the old days, I know not now, for Tulsa, it ran up to 6 hours. And this could run 3 to 4 hours now. And I think that's important. And what you also mentioned, I found off a previous paper, that surprised me because that was in sort of small print. They called it eliminating rectal gas. So the patients had to be on that diet you mentioned 2 days before. And, a clear diet 2 days before is not
it's one day. It's 1 day before.
1 day now. Okay.
But it is a bowel prep. It's like having a colonoscopy, same idea.
Exactly.
And that I can tell you also from personal experience, not fun, but it's also not the end of the world.
No, it's not. It's just, I'm kind of searching for these catches, and I think if they're all listed. No, but so just up to you. I'm just saying for advertisements and people, they should list those.
Yeah,
so I know what I'm walking into.
The strength of this technique is the precision. Like you really see exactly what you've done. Your goal is to heat the tissue. You can tell exactly what temperature every part of that prostate's been heated to. You get a cold spot, it's real. You have to go back and treat that. You don't have that with the other technologies. And I think precision is what's going to determine ultimately which of these technologies wins. But the other piece has got to be kind of practical, fairly efficient. And there's no question with this technology, it's complicated. And there's a lot of moving parts, and any one part not being quite right, it all grinds to a halt. So I think that will come with more experience. People get over the learning curve. They learn how to anticipate the glitches. Takes a while though.
No, I understand, but right now it's a cash situation, right? Someone's going to pay a lot of money cash-wise in the States in order to get it, like they would the focal therapies. Isn't that probably true?
I don't know what it's going to be. We don't even know ourselves what we're going to price it at, but it's probably going to be in the same ballpark as HIFU, which is, I don't know exactly. It depends, but somewhere around 20,000.
Okay.
It's a big chunk.
So it will compete with HIFU and the cost of the other focals.
Yeah.
Okay.
It's interesting. The biggest, the HIFU doctor with the largest experience in the States has also taken on Tulsa. And I'm not sure how he makes that distinction between who should have one and who should have the other. But it's interesting to me that the highest volume Tulsa doctor is also the guy who's early adopter of Tulsa. The highest volume HIFU doctor is the earliest adopter of Tulsa.
Yeah, how do you decide which one? And maybe you can give me a hint here in terms of if I'm in the urethra, I'm in that area versus being in the rectum, I'm in
Yeah.
an anatomical different space, right?
Yeah.
So I'm saying, then is there, for example, so if I'm in this anatomical different space that normal people don't get to play in, and I'm in sort of the middle of the prostate, is it possible that certain types of tumors are better candidates? For example, ones that are anterior, you know, they're more to the
For
front
sure.
as opposed to the back, or is that not an advantage?
No, I think for sure that's an advantage. Like, you're not restricted at all by location. The two big issues with HIFU, and of course you also have cryoablation, you have electroporation, you have interstitial laser ablation. So, you know, there's all these competing technologies. So the appealing thing about Tulsa is that the probe is in the middle of the prostate.
Right.
So there's really no restriction in terms of the area you can reach or of volume. So volume, really large prostates aren't good cases for HIFU by and large, because there is a definite restriction in terms of how far the energy can reach from the rectum.
That's right.
And the other thing I would say is a rectal injury is definitely a concern with transrectal HIFU. Now, the incidence of it should be low, but ironically, one of the safety features of HIFU, we're talking about transrectal HIFU now, not Tulsa, is the beam moves back and forth from one side to the other, so that there's a kind of cooling period after treatment before the energy comes back to that spot. When you're doing focal therapy, however, which is, I think, what HIFU is being used for primarily now in the United States and certainly in our center, you don't get that safety feature. So the energy is much more concentrated in one spot. And ironically, although you're delivering a lot less total energy, the rectum is more at risk. So you can, if you're not careful, to some degree this comes with experience, you can get a rectal injury, which is quite devastating. We think that risk is going to be significantly lower with the transurethral approach because the energy is not being directed through the rectum at all.
Can you explain, so you do think there are anatomical advantages, especially for an anterior tumor. Can you explain in your words why anterior tumors make people nervous? And then after you explain that, if you think it is an advantage, because that's what I kept thinking about. Okay, if you're in there in the middle and you've got a big anterior tumor, that could be an advantage. But then I thought, well, then Klotz has got to answer the other question. If you're in this location, where are you at an anatomical disadvantage, or are you? So can you answer both those?
Yeah. Anterior tumors are not fundamentally different. They're just a little harder to diagnose. Their biology is not really different grade for grade. You can get, because they're harder to diagnose, they can sometimes be large. But that's just a feature of the fact that the biopsy tends to be done transrectally. I think that whole issue is going away now with targeted biopsies and imaging. So there's no particular anatomic location that Tulsa would be, I think, worse for. It's been said that for apical lesions, I mean, the problem with the apex is it's close to the sphincter.
Right.
So people have promoted either electroporation, although there's quite limited experience with that. Like that's a therapy that's only been done in a handful of centers that I'm aware of. That it may be better, electroporation may be better for anterior tumors. This is really mostly speculation. No one has ever done any kind of comparative studies to look at how the morbidity or the oncologic effectiveness compares in a randomized population between the different technologies. That's really an unmet need as far as I'm concerned. I think what it comes down to is that clinician expertise really makes a difference. So the difference between practitioners is probably greater than the difference in outcome between these technologies by and large. So it's going to be very hard to really prove that one is superior to the other.
Yeah, but I think you're going to run into the same problem. It's not a problem. This is what we're used to. The people who do the high volume, the ones who do a lot of cases, are the ones you're going to lean toward, because that experience matters. The curve matters. It doesn't matter if it's radiation surgery. The curve matters. But I really thought, just to explain to the audience, when you have a finger in there and you're looking at the peripheral zone, you're feeling the prostate. Most of the tumors end up in that peripheral zone. In the when you're palpating, but on the other side, the complete other opposite side of the prostate is the anterior area, and sometimes tumors start there, and they're hard to pick up. And I just thought that might end up being one of the advantages here. That was just something I was thinking. Yeah.
Well, the term, the PET tumors, prostatic evasive anterior tumors, was coined a few years ago. And the idea is, before we had imaging, you had to be lucky to find these anterior cancers, because the tendency is to about 75% of prostate cancers are in the peripheral zone, which is more posterior, more near in the back part of the prostate. That's relatively straightforward to biopsy. Just for anatomic reasons, you have to work hard. The needle has to go a lot further. It's more uncomfortable for the patient. It's harder to anesthetize that part of the prostate. So before we were doing targeted biopsies, it was acknowledged that we were tending to miss those cancers.
Yeah, when you put the finger there, you're touching the peripheral zone. You're not touching the anterior part. If you got a huge tumor.
You can't feel it.
You can't feel it at all. So for patients who are told they have anterior tumors, those are the buzzwords. You got to ask, how does that affect my potential treatment overall?
Right.
Okay, a few more questions here, and then we're good overall. There was an impotence rate. I call it, but it's actually erectile dysfunction. I don't like that word anymore. There was still a persistent erectile dysfunction rate. A strong minority of men had it. Do you want to comment on the side effects of erectile dysfunction and incontinence after Tulsa? And Part B, I hate to add Part Bs because I don't have the memory for Part Bs, but do you believe in a penile rehabilitation or some type of rehabilitation when someone gets Tulsa? In other words, they try to prepare for some type of risk for a side effect, so they take something or do something that mitigates that risk.
So actually, the data was pretty good, Mark, that there was a transient effect on erectile function that lasted somewhere between 3 and 6 months.
Okay.
But something like 85% of the patients who had good erectile function, this was all documented by validated questionnaires, the patients who had good erectile function at baseline recovered that function in somewhere around 85% of cases. So I actually think it's quite good from that perspective. Okay. And the second thing, of course, is, I anticipate it's going to be used mainly for partial gland ablation, where that becomes even less of an issue.
That was going to be one of my questions.
As far as penile rehabilitation, I have to say I'm a skeptic. To me, it would be so easy to show in a randomized trial that penile rehabilitation after prostatectomy, for example, works. And that the data that there is, people have done randomized trials, not very convincing. So I am not a erectile dysfunction practitioner. I have a colleague who does that very well, but I don't think fundamentally that penile rehabilitation really works. Now, by penile rehabilitation, what we're talking about is not a therapy to improve erections, because we know the pills do that. The question is, by using medication or injections early on, do you improve the ultimate recovery of spontaneous erections? So there I am frankly a skeptic. Unfortunately, it'd be nice if it worked.
That's interesting. Maybe if we put up lifestyle changes up against some of these pills, they would be equal or not superior, but that's a whole other conversation.
Yeah. And I should say, in the ED world, they very much believe in penile rehabilitation. So
they do.
My view is my personal view, and it's it's not that most people are much more optimistic about it.
I think they are very optimistic about it, but I always kind of go back to one of Mulhall's papers at Sloan Kettering that showed one of the biggest predictors after surgery or other treatments of regaining erectile function and doing better was essentially how healthy you were going into the procedure. And if you continue to take care of yourself after the procedure, as opposed to popping a pill and going, let magic happen.
Right.
You got to be part of the magic formula, right?
Right.
So you had a range in this trial of BMIs. Are you ready for this?
Yeah.
20 to 43. So you had some very skinny people and you had some very large people that was with mass. Do you see that as being an issue in the future in terms of size, or does that have nothing to do with anything in terms of weight and this procedure?
Everything is more difficult in people who are extremely obese. But I would say beyond that, there really was no issue of obesity preventing the procedure from being done effectively. Okay. You can be criticized if you don't have a range of body types, for example. Or same is true, you aim for diversity of race in terms of the makeup of a clinical trial cohort. So, it's good to have a range, and it really didn't make much difference.
Okay. So now the last items, and I'm going to let you play one song to lead us out here. The last items I want people to understand before you give final recommendations is you've kept mentioning in videos, I told you this last time, and now I see it coming up in the paper, that prostatic calcifications, calcium buildups in the prostate were problematic for Tulsa.
Yeah.
And so can you walk us through what prostatic calcifications are, why they are problematic for this and maybe other techniques, and how do you check ahead of time that you're not going to be treating a patient that's got a ton of these things that can interfere with treatment? So just comment on calcifications.
Yeah, so first of all, just to be clear, the problem was large calcifications. So it's very common for patients to get tiny prostatic calcifications or stones. They're called corpora amylacei. They're basically calcified material in ducts, the prostatic ducts. They tend to always occur in the same place, which is at the junction of the peripheral and transition zone. Exactly. They're more the norm than the exception. Like very many people have these and they're almost always small, and that was not an issue. But you're using ultrasound energy, which goes through tissue but bounces off and is reflected by hard material like stones. So what happens, and this was our experience, if the patient had a calcification greater than 1 centimeter, which isn't that common, maybe 5% of people have that, of men, then the tissue beyond that did not get adequately treated. And in other words, the tissue that's further that is in the line of the stone and blocking the waves. And the other concern, of course, is that the ultrasound energy is bouncing off this stone, and therefore, maybe bouncing reflected back and causing some injury to the urethra, for example, and so on. So, and in fact, we found that one of the few predictors for persistent disease was having large calcifications. So, that's what happens when you do studies like this. You learn things, and that we learned that lesson loud and clear. So I would say for the majority of patients, not an issue, but for the ones who have large calcifications, they've got would not be an appropriate therapy, or else they have to have that dealt with beforehand.
Yeah. So when I'm thinking Tulsa, I'm thinking I want someone who's done a lot of these procedures. I'm going to watch for how this gets covered by insurance in the future. Right now, I'm probably paying out of pocket. Right. And calcifications. I mean, how can the doctor just check ahead of time? What device do they use?
Yeah.
What device?
So these show up very well on routine ultrasound.
Okay.
So particularly transrectal ultrasound. So these patients were screened. Now, of course, patients have an ultrasound when they have their biopsy. So you generally we'll know that they're there based on the ultrasound findings done at the time of the biopsy. And if necessary, you can do it again.
But the having calcifications in the prostate, so if we see calcium in the arteries during a coronary calcium scan, or you see a calcium buildup in a CT in the kidney or stone, having calcifications in the prostate is a benign situation. It's not a problem in and of itself, right?
This is not like atherosclerosis where, if you have calcified blood vessels, that tends to reflect a systemic issue of atherosclerosis and has major health consequences. This is localized. It's probably due to some chronic inflammation in the prostate, and the result is some obstruction of ducts and stones forming. And it's so ubiquitous. We see it all the time. I don't really think it has any significant health consequences.
But it's good to know that, you can run into a situation with those, and what are those when you're thinking about this.
Right.
Do you have any more comments on the side effect profile of this before I mention my last comment and let you go to finish us with the piano? I mean, when I look at table 2, it shows rates of hematuria, blood in the urine, ED, incontinence, pain. I mean, of course, they look favorable at 12 months later. Anything else that patients should either expect or talk about with their practitioner if they're considering this that I'm missing before I add one more comment?
I don't think so. I would say the side effect profile was really favorable, better than I actually expected, considering that there's so much reduction of prostate volume. But most of the patients really sailed through it. I had one patient who developed urinary retention afterwards. In retrospect, he had a bladder that was not contracting properly. It wasn't due to obstruction. And I scoped him, and that cystoscopy video has actually gone viral because it's amazing. The entire inside of his prostate was gone.
Really?
It was like looking in after a bomb crater had gone off, a controlled bomb crater. After a bomb had gone off, looking at this, it was really, really extraordinary how effective this treatment had been at just eradicating all of his prostatic adenoma.
So do you think there's a possibility? Well, that's part of my next question, but the age range was remarkable here in the trial. The median age was 65. The age range was 46 to almost 80.
Yeah.
That's a pretty wide age range. I don't know if there's any comment. I mean, one comment is, wow, you had some really old patients and you had really young patients. Any comment about that?
It's basically my earlier comment. We were just really anxious to get patients to undergo this therapy. Yeah. And I mean, I guess one caveat I would say it's remarkable. I've been kind of a clinical trialist. I've done many trials and led a lot of them, and there's no question that trials tend to drive intervention. If you have a patient if you're a trialist and you have a patient who's a candidate for a trial, it's very appealing to offer that trial to the patient. So, did the 79-year-old, I don't know if the older guys had Gleason 6 prostate cancer, was this really an appropriate thing for them? Well, you can say that in retrospect. I think I certainly acknowledge that when you have a clinical trial and you have patients who are eligible, they tend to be offered that trial, rightly or wrongly.
Yeah, I mean, at the end of the day, I think a human being would rather see a large age range. You can argue the ethics and morals at a different time.
Right.
I'd rather see a wide age range than some compact, tiny age range.
Right.
So I always like to, what I like a lot of things about you, and sometimes you make me crazy when we are sitting at dinner and we're arguing about something, especially when it comes to maybe supplements or, I don't know, trials. But that's the fun part. That's how I see politics one day, that I've had a number of heated arguments with you, whether it was in Colorado or in Toronto, and it seems like an hour later, you know, we're having a beer and we move on. It's just life. I accept. I like that. That I find attractive.
That's becoming harder to find, though, Mark.
It's becoming very hard to find, and that makes me sad. So what I always do when I do these interviews for you is I always go find the biggest critic of your clinical trial, and I want to see what they have to say.
Yeah.
So I found that critic, and that critic will remain nameless. It's a U.S. physician. I thought the criticism was valid, and it's not that bad. It said, in summary, and this is talking about previous data, but I think it applies to now. It says, in summary, MRI Tulsa should be developed for focal and not whole gland ablation. So you just hit some areas. Quit trying to treat the whole prostate, Klotz. That's what this person's screaming with exclamation points. How do you want to answer that before we move on?
That's not difficult to answer at all. So first of all, the point of this trial in part was to get FDA approval. FDA will not approve a technology for focal therapy. You can't get a new technology approved, at least until now. And it was certainly the case when this trial was designed. So everyone involved in this project had the same idea that this was going to be a treatment probably mainly used for focal therapy. But to get the technology approved, you had to do a study of whole prostatic ablation. Huh. Well, and you know, the other thing, this is my personal experience. I've been doing HIFU for more than a decade. We started doing whole gland ablation with HIFU, and the idea was that this was going to have much fewer side effects. And whole gland HIFU, when you treat both lobes, the energy delivered is so substantial that the tissue is semi-liquefied. Mm. And when it cools, it fuses in the midline, and you get obstruction to the flow of urine, and the patients get side effects, and they are not happy. With focal therapy, this doesn't happen at all. You may have some changes in tissue consistency on one side, but there's nothing for it to fuse to. So I think all of these kind of energy-based technologies have as their primary focus partial gland ablation, whether that's, you know, a third of one lobe or the entire lobe or 1.5 lobes. The idea is you spare some tissue, and by doing that, you preserve function. And, you know, that's the concept. So in a sense, I agree with them. The patient with substantial bilateral high-grade cancer, that patient is, I think, better off with surgery or radiation. But we have so many patients now who have lesions that are confined to one side or to 1/2 of the prostate, and we're still doing the equivalent of the radical mastectomy in these patients, where, you know, partial mastectomy has become the norm in breast cancer, and it's a similar kind of shift in prostate cancer.
Almost 50% of the patients in your trial had unilateral one-sided disease. Mm-hmm. 50%, 1 out of 2. So then if you're selling me, not you, again, just relatively speaking, patients are bombarded by people that want to give them therapy. If you're bombarded by this, so then the implication in the advertisement is, if this becomes a focal therapy, you're targeting a certain area, then theoretically you should be able to go back in again if there's another focal spot at some point and hit another area. Am I right or wrong?
Absolutely correct.
Okay.
I mean, for example, the French HIFU experience, 44% of their patients were retreated. Like, their whole approach, it's not my approach, but theirs is to say, yeah, well, it's one treatment, maybe 2, maybe even more. We just keep treating focally until it's all gone. So that's a much different mindset than identifying a patient with one significant cancer that you're going to eradicate with the intent of that being curative therapy. But for sure, these treatments lend themselves to repeated therapies if necessary.
Anything else you want to say about Tulsa as a, I assume there's a lot more patients that have had it now. There's more research going on. You have other papers coming out in the next 6 to 12 months to give updates. How are we going to do with this on research?
Yeah, so there is a 2-year fall built into this. To be honest, I'm not sure what the status of that data is right now. It's one of these multi-center things where, I haven't seen the accumulated data. So there will be some follow-up. And I also know that the groups that are starting to do this off protocol are maintaining their data in a registry, and that will be reported.
Okay, that's great. By the way, I know you're still excited about capsaicin. We sell capsaicin patches in the United States. Not we, but it's still a supplement and a topical product that helps with arthritis. And now there's a company that actually has an injectable that's looking at treating osteoarthritis that might get FDA approval soon.
Really?
So there's a lot happening with the supplement that you're interested in. Not that I'm as excited about you, but I'm excited in medicine about capsaicin in general as another example of how sometimes over-the-counter things actually do help. They really do help. So I want to say that I took you through a lot of catches. We went way over time. And, I just wanted to answer the question, was Tulsa a JAFT, J-A-F-T? Is it just another focal therapy? And I think you went through it, that it has some similarities, some uniqueness to it. We gave some patients tips and even a lot of clinicians tips on how to look at this data. I think this was incredibly informative, and I appreciate you letting me go through some of the Achilles heels of some of these clinical trials and answering those questions. I really appreciate it.
Pleasure.
At the same time, I want to let you finish with one more song and piano. And this is the first for us. We've never had someone start and finish with a song on the piano. So unless you have anything else to add to the audience, who's going to be huge for this, I'm going to let you play.
I don't know how many of the audience were present when I was in Los Angeles last time, but I gave my talk, and then Mark sprung on me as a complete surprise. He pulled the drape off a piano, a grand piano sitting at the side of the podium, and said, "Play." So I don't get rattled that easily, but I must say that was a shocker. So I have also never given a talk like this, starting and ending with a piano, but I'll play one more tune. This is Misty.
Man, that was really good. I felt like I should have brought my wife up here, and on our next anniversary, you should have played that song, and I should have felt like I hired you.
Yeah.
Right? Isn't that that's a beautiful song?
It is, yeah.
How long have you been able to play that song?
That's a standard.
I know.
But I mean, I don't know. I've been playing it for years, but that's the thing about music. You always got something more to strive for. So that arrangement, I don't know. I've been playing that for the last year or two.
Yeah, for the audience at PCRI, when I surprised you, it's not easy to throw Klotz off, but the fact that he didn't know there was an actual piano next to the stage shows you how well we camouflaged that piano, my friend. And I have never seen you so semi-excited, but also scared to do something.
Right. Very
that was a classic moment. Hey, I'm really glad you got a chance to show your skills. I mean, your piano playing is great. The song was great. Yeah. Prepare prepare maybe not to keep your day job.
All right. Well, it's been a pleasure talking to you, Mark.
It's always been a pleasure talking to you. Thanks for all the time you always give me, and thanks for putting patients first and all the education you provide. And these are such wildly popular interviews when I have them with you. I think it's really a testament to how people really look up to you for advice, and how I'm so glad you could deliver in many ways, not just through the piano, but through talking about your latest achievements. So hope to see you soon. I really do. And thank you for all your time.
It's been a pleasure. Good
pleasure
to see you.
too. Thanks.
Right.
Thank you.
Bye-bye.
Do you want to play on your way out as we close screen?
Sure.
I'll have them fade out the screen. So PCRI people, fade him out as he plays in the future.
Thank you, Dr. Moyad, and thank you, Dr. Klotz. We at PCRI really appreciate the time you took to explain all that to us, and I know the patients do too. If you would like more information about anything that they talked about today, you can visit our website at pcri.org. Also, don't forget to subscribe to our YouTube channel. We come out with new videos every week and webinars like this every month. We really appreciate that you trust us with your health and your information. We just love being a source for you guys. We hope you have a great week, and much love from PCRI.